Thank you. Thank you. So our speaker today is, lost it, Jennifer Alexander.
Hi. Can you hear me?
Yes, I can.
Okay.
Okay, let me just do a little introduction just to say that you're going to speak about pelvic floor physiotherapy. The question was, will it help you? And you say, or can it help you? And you said, yes, it can. So I'm going to just allow you to get going, Jennifer.
Okay.
You can introduce yourself as well. Okay.
So my name is Jen. I'm a pelvic floor physiotherapist in Fonthill, Niagara. I graduated from Queens back in 2006. And since then, I've been practicing in like the private sector, as well as case management for home care. And then with my kids, I did a deviation back into the private sector for pelvic floor physio. So I'm just working to bring up my screen here. Can everybody see my screen?
Yes.
Perfect.
I can. Anyway, yes.
Okay. Presenter view. Okay. So this is kind of the outline that I kind of put together, just to briefly touch on a little bit about what made me become a pelvic floor physiotherapy, a little bit about our services, basic anatomy in order to understand why something is happening to our bodies. You really need to understand a bit about the anatomy, the physiology, and we provide that education to everybody. Going over some misconceptions, just talking a little bit about incontinence and prolapse. Those are two very common conditions that we see at the clinic. And then kind of what to expect at a pelvic physio assessment. So this is my little guy. You can see he's quite heavy, 9'2". He was an induction after 48 hours. Our vitals weren't doing very well. I did have a panic attack. It's important to note that I've never had a panic attack before. And ultimately, it ended up with an emergency C-section. At Grimsby Hospital, when you have a panic attack and an emergency C-section, you check off at least two of their boxes, and that puts you on the postpartum depression pathway. And with that, I was hospitalized for over a week to make sure that I had the best chance of not developing postpartum afterwards. 6 weeks after after the birth, my OB did a pap test. Now, my question I always ask health professionals is why. And the reason was because sometimes postpartum there can be some cervical changes, so they always like to monitor that. And that was, wow, that really, really hurts. I've never had that. Starting to ask questions. Why did that hurt? Baby came out of my tummy. I did not have a vaginal birth. And so that kind of what led me down the route to become a pelvic physio. When I came home from hospital, it was very cold in the house. I recognized a huge detachment in the house. And so I knew something was off. Time was standing still. Periods of where you're very emotional, you're crying. And so I knew something was wrong. And so I enrolled in counseling within Fonthill. And I knew that pain that I had experienced, and it was starting to get worse. I couldn't even use a tampon eventually because the pain got so bad, like this burning pain. And so I searched everywhere for a pelvic physio. That's all they did. I wanted to get through this as fast as possible. I was going to go see somebody that saw clients from morning until the afternoon, and they were all pelvic clients. And so I ended up driving to Hamilton to Pure Pelvic Health, and that's where I was treated. During my mat leave, I took 2 pelvic courses, levels 1 and levels 2. So you can be a pelvic physio after level 1. That really looks at bladder leakage. Level 2 looks at the other conditions, and level 3 is pain. In 2018, this is Charlotte. She was born. She was a planned C-section. I was not going to go through that again. And then I completed some more pelvic courses as well. And how I started, it was really just a journey to help other women, recognizing that there wasn't a need, there wasn't a specialized place in Niagara that focused solely on women and pelvic health. And so I opened up a website online and I converted our office, which I'm in now, into a treatment room. And I slowly started one patient after the other and helping them along their healing journey. I eventually got so busy, my husband said, "You need to find a new location." He was on shift work. And so it was really hard because of those sensitive conversations. I would not allow him inside the house during that time period. And so we renovated a place. This is the building. We renovated the main floor. I was able to make it my own in terms of what I wanted. And what I wanted was private treatment rooms where we erected walls. We put soundproofing within those walls. We did our best. The reception area is completely closed off for privacy. So my screen just froze here. There we go. So there's one treatment room, private, and that's just our charting area there. That's my mom. And so we do some Pilates rehab too. The reason I developed this, the Pilates rehab, was I was having a lot of women postpartum. They were having hip pain and back pain, and we know that those are all connected. 75% of anybody who has back pain has something going on in the pelvic floor. And this is just the way I help them to try to get stronger so that they can carry their kids up and down the stairs, put those babies in the car seats, in and out of their car with better ease. And so with that, I also recognized the need that I need to bring in some other health professionals to help me along. The first one being counseling. Counseling and pelvic physio, it helped me immensely get through that time. We also brought in a naturopathic physician, osteopathy, and we have 2 services coming soon. Occupational therapy is going to look at breastfeeding assessments, and then we have, some of you might have heard of the MCELA chair. We have that coming along too at the end of the month. So when it comes to pelvic health physiotherapy, what exactly is it? Well, the pelvic floor, it's a group of muscles. They're inside of us. And so this is an example I give people is if you close your eyes, and you can do this now, put your arm behind your back, you know if your hand is open or closed. If some fly landed on it, you know that. But we haven't developed these very good sensory or motor programs within us with respect to our pelvic floor, so nobody can tell me what their pelvic floor is doing at any point in time. We know that as a muscle, it can get tight, and when it gets tight and it gets too tight, maybe that person's going to have pelvic pain, like I did. Maybe they're going to have some bladder leakage. And then the other way, you can have it too loose or too not enough tone in it. And again, you can get bladder leakage with that, maybe getting some heaviness and some pressure. So you just remember it's a muscle. And so the next photo is a better photo. You can see at the front, it starts from like here. This is the tail, the pubic bone wraps all the way down like a hammock to like the tailbone there. So it supports these guys. That's your bladder. That's the vagina and the uterus. That's the rectum. So it gives some support to that. They also have muscles that go around the area you pee from and the area where we evacuate stools. And so they tighten up to keep everything in. And then they relax to let everything out, right? They have a role in sexual health, in stability for your back, your hip, as well as pelvic congestion, so swelling. So muscles are pumps. Muscles need to work in order to pump fluid out of an area back into the kidneys where we eventually pee it out. These are some conditions that we do treat quite often at the clinic. So bladder leakage is one of the most common ones that we see, overactive bladder and urgencies. So having to use the bathroom very, very frequently. Constipation is huge, or maybe loss of stool. Pelvic organ prolapse, that's where we'll talk a little bit more about that later, where we don't have as much support holding those organs. Back pain, hip pain, pelvic pain, dyspareunia, pain during intercourse, coccydynia, tailbone pain. So I've had women, whether it's during the birth process, or maybe they fell on their tailbone and their tailbone is still giving them some pain. Chronic pelvic pain, endometriosis, and then the chronic bladder infections. Those are quite interesting. You can have some women will have repeated signs and symptoms that they have a bladder infection, but they go to their physician and the dip test and the CNS, the culture test is negative. And so they won't put them on antibiotics, or maybe they will just in case. And so you can really alter the vaginal microbiome in those cases, but at the same time, the pelvic floor muscles, if they're really, really tight and squeezing those nerves, you will get the same symptoms as a bladder infection. We also treat so pregnant women. So when they come in, we do a lot of birth education, a lot of labor prep, teaching them what is the best position, how do we breathe during birth, what to expect, what are some ways that we can manage our symptoms during the birthing process, and what to expect afterwards. What should rehabilitation look after? What can we do? What can't we do? We also treat children. And this was from, again, another personal experience with my son, with the bedwetting, which is very common. A lot of myths around there. My child will grow out of it. That is a myth. Ankle paresis, that is maybe they're soiling their underwear during the day. Bladder leakage, constipation. So just to give you an idea of some of the areas that we do treats. So when we talk about bladder leakage in Canada, it is quite outstanding that there's so many women and men who suffer from bladder leakage. So the statistics are 1 in 3 females and 1 in 9 males will have bladder leakage, which is about 3.31 million Canadians, right? When I did a presentation for the Brock students the other year, I took the class, divided in half, and I had half of them put their hands up. The other half, I had look at the individuals with their hands up. And I said, this half, so 50% of you will end your life wearing incontinence wear. It has a huge impact on quality of life. The statistics reveal that only 1 in 12 are known to their healthcare providers. There's a multitude of reasons for this. It's embarrassing, it's right? Maybe they don't feel comfortable talking about it. But the other end, maybe health professionals haven't asked them. After my birth experiences, both of them, I was never asked, do you have any bladder leakage? How are your bowels working? Do you have pain during intercourse or with a tampon? Nobody asked me anything, and nobody provided me with any direction of what to do. It was only that I was a physio at that time, and I knew pelvic floor had something to do with this area. And that's what kind of led me into that journey. These are 3 common misconceptions. So it is a misconception to think it's normal to have bladder leakage after childbirth, to think it's okay to leak as you get older, and that there's nothing that you can do about it. So when it comes to bladder leakage, and we look at the social consequences, it's I see this a lot. The people don't want to go out of the home for fear of bladder leakage, right? The isolation, the depression that comes along with that. It impedes physical activity. Well, if I get up and I go for a walk, I'm just going to be wet afterwards, or is somebody going to notice that I smell if I'm behind them at the grocery store, right? And it really, really affects people. When you look at the cost, so this is broken down from one of the slides I had from our instructor. It's about $6,000 a person who experiences bladder leakage will pay on average a year for incontinence support. And a lot of people say, well, pelvic physio is expensive. It is compared to like an orthopedic, but you don't need as many sessions ideally. The last person I discharged last week, it was 3 sessions and she's no longer leaking, right? But everybody's always going to be a little bit different. When it comes to bladder function, so you have, this is the bladder, right? This is it relaxed. And you can see the bladder here, it's full of urine, right? And then the bottom is the pelvic floor muscles, okay? And so when it is filling up with urine, this pelvic floor muscle needs to have enough strength to close this off to keep the urine in here. And when we sit on the toilet, the pelvic floor muscle relaxes, so it opens up the exit. so the bladder muscle can squeeze that urine out. This is the reason I tell many, many women who come to my clinic to stop doing Kegels sitting on the toilet, because the toilet needs to be associated with this muscle relaxing to let everything out. Okay, so people will say, well, what is normal, Jen? Well, you should pee about 5 to 8 times a day. Okay, I have people coming in, they pee 30 times a day. That is a problem. That's going to impair your function day to day. You should be able to put off the urge to pee, but at some point you can't ignore the urge. You need to go. Bowel movements, you should be emptying everything you ate the day before. We typically will empty in the morning. There's a natural reflex that happens. No straining, no pushing. And you should be able to have pain-free intercourse, pain-free sitting, pain-free walking, pain-free sitting. So this is what I look for when I sit down with every client to see what's changed. When we talk about bladder leakage, there's tons of different types. The most common are stress, urge, and mixed, and we'll talk about those very briefly. Urge is that you got that strong urge that you have to pee, you got to go right now, and you're running to the bathroom, and you may lose urine on the way, you may not, okay? You're not able to postpone that urge, it's now. Stress, that is when you have a huge amount of pressure in around that bladder. If you think about like a water balloon, such as you're coughing, you're sneezing, going from sitting to standing, and you're squeezing that bladder or that water balloon, and that pelvic floor muscle is just not strong enough to counteract that pressure. That's stress incontinence. Mixed incontinence is what I see most often. It is a little bit of both. And so we got to treat both. So when it comes to like, well, how do you treat this? We have to retrain the pelvic floor. Whether it's in a too tight of a position or a bit of a too loose of a position, but we know retraining the pelvic floor function is the first line of defense for stress incontinence and mixed incontinence in women. Level 1 graded evidence, it just means when they classify levels of evidence, it is at the very, very top. It's considered a gold standard. When it comes to prolapse symptoms, so this is where like one of the organs maybe just doesn't sit in the same position that it used to before. We can get different symptoms. Maybe you feel like you have pressure down there. Maybe there's a bulge down there. Maybe we can't empty our bowels as well, or our bladder. We actually see quite a bit of this. We'll see maybe after childbirth, but we also see it after menopause. And after menopause, the statistics state that there's about 41% of women who are older than 60 who've not had a hysterectomy will have some sort of prolapse. But it's also important to know that after a vaginal birth, having a little bit of prolapse is normal. We really need to start normalizing that. There's a lot of fear that's induced when somebody goes see somebody and they're like, oh, did you know that you have a prolapse? And so through education that we're providing at the clinic, we're really trying to normalize that. To have a little bit, it's actually okay. It's when it's interfering with your bladder function, your bowel function, your sexual function, that's a problem, okay? And again, there's high level of evidence that retraining these pelvic floor muscles to give those organs a little bit of a boost does help. I like this diagram. So it's a hammock. So the pelvic floor is like a hammock. And you can see it gives some lift to all those organs. And so this just classifies it based on which organ has moved a little bit out of position. And so the yellow, we can see here, is the bladder, the rectum, they call that a rectocele, or the uterus. Uterocele is what they would call that. But it's a nice visual just to give a better idea of how the pelvic floor lifts up those organs. Another visual, I draw this diagram out for a lot of my clients. So the boat is your organ, and the water is your pelvic floor muscles. So they give lift to the boat from below. And then you have those guide wires, and they kind of stabilize the boat from up above, right? And so when you have less water and maybe some less structural support from those ligaments, the boat kind of descends. And then maybe at some point of threshold, somebody's going to develop some of those symptoms that we talked about. This is just a study that was done that, again, it concluded that pelvic floor muscle training, PFMT, is actually very effective and very cost effective in reducing prolapse symptoms. And again, just like incontinence, it should be the first line of management instead of jumping right into surgery. Pessaries are another option. They're a passive device they're a device that's inserted and they provide passive support. So they're like a life buoy. They get a little bit of a lift to those organs as well. This is Dr. Kegel. He is the individual that came up with the Kegel in terms of doing a vaginal examination and being able to feel those muscles actually contract. Because remember, they're inside of us. You can't feel it. You can't see it. I've had people come in and say, I do my Kegels. We check. They're not doing a very effective Kegel. I have other people who come in, they say they're doing their Kegels, we check, and guess what? They actually are doing it very, very good. I was able to confirm that, yes, you are contracting it properly. Okay, so this is to denote that it's a muscle. You can have too much tone and you can have too little tone, right? And you can have pelvic floor symptoms based on either one of them, but the treatment is going to be a little bit different. So again, those muscles can be too tight, such as this lady, or not enough tone, kind of in like with this picture over here. So when you come to see somebody like myself, and so the treatment sessions are typically about an hour in length, that initial assessment, right? We spend a lot of time just talking about what are your symptoms, the symptoms that brought you here. We really talk about your goals, like how are you hoping that we can help you? What are realistic goals? When it comes to the physical assessment, you really need to look at the back. There have been people that have come in. I haven't done anything pelvic floor wise because it's actually coming from their back. All those back nerves innervate the pelvic floor. The hips, you need to make sure we look at the hips, the mobility. How does someone breathe? Our breathing muscle is connected to our pelvic floor. They work together. And we will often recommend an external pelvic exam, an internal exam, but it's really important to note that this is not for everybody. Not everybody consents to it, and that is okay, because there's things that we can do based on someone's history to help them get to where they are. So I have treated bladder incontinence, prolapse symptoms successfully, virtually. Right? And there's nothing physical there. And so that is great as well. We really need, as practitioners, to practice from a trauma-informed lens. We don't know the history of somebody that's coming in. I've had people come in, and even though they've completed their intake forms, it's not until we start having a conversation and they feel comfortable, and they'll say, you know what, I didn't include it in the form, but I was assaulted when I was younger. And so having a therapist that's trained from that trauma-informed lens knows kind of how to proceed. They are able to recognize signs that may trigger some symptoms and what to do when that happens. We also, after going through the physical assessment, we would have a conversation in terms of what did I find out during that assessment? What does it actually mean to you and to your symptoms as well? What are the treatment options that are available? And this is going to be completely dependent on assessment findings, on somebody's goals as well. Maybe we need to strengthen those muscles, right? Maybe they don't have enough tone. We need to strengthen them. Maybe they have too much tone and we need to do the opposite. We also use biofeedback. We do this a lot with our kids. Nothing is invasive there. We talk a lot. There's a lot of education that's provided in terms of bladder health, bowel health. Oftentimes when you regulate the bowels, you will notice changes in the bladder health as well. And we do this through different diaries, whether it's fiber diary or a fluid intake diary. We also do some manual therapy, whether it's internal or external. to help with the symptoms that somebody might have. The other device that's coming, I don't know if some people have heard of this, is called the Emsella chair. It's actually very interesting. You sit on this chair, it produces an electromagnetic wave that actually tightens up the pelvic floor. And so it actually tightens it at an intensity that we voluntarily cannot do ourselves. It is not for everybody. I've seen people where this has worked very well. I've seen people where it hasn't worked very well. But it is a treatment option that is out there. And so this is an example so here, for example, the top line, let's look at that. That's like your muscle contraction, what we can do on our own. And then this is what they call a super maximal contraction. So something we cannot actually do this. The machine does this at the muscle level itself. And so with pelvic floor muscle strength training, if we're able to get somebody to like 90% better and they really want that extra 10%, then this would be an option to try to get them that last 10%. So we're excited to bring that to the clinic soon. And that's, I went through this fairly quickly. I wanted to touch on the various areas of the pelvic floor and kind of what to expect, as well as the different conditions that we do treat. So I just want to say I am thankful that I was able to be given this opportunity. I don't know if anybody had any questions that I would be more than happy to answer.
Thank you, Jennifer. I just want to point out that because of the confidentiality and the fact that this will be placed on our YouTube channel, I will stop the recording, and that way everyone can feel comfortable asking.
Sure. Yeah, absolutely. I appreciate that.
Okay.